Okay, which of the following, this ends the section there. So we come to the next independent question. Which of the following is not an indication for airway protection? So we have been talking about airway a lot. Unconscious patient, profound septic shock, foreign body aspiration, caustic ingestion. Okay, so you need to understand some concepts first. Talking about airway. So the indications for airway protection can again be grouped into A, B, C, D, E, F. Easy way to remember. I'll give you some examples. So first airway indication stands for airway itself. So if there is an airway collapse, like in the previous questions we have seen, vomitus in mouth, right? If the patient has severe maxillofacial injury, you need to protect the airway. Right? These are some examples of airway indications for getting the airway secured. If there is an abnormality primarily in the airway, go ahead and secure the airway. B stands for breathing. So there are some breathing indications as well. If the patient requires mechanical ventilation for some reason. Right. This could be a severe pneumonia, ARDS, COPD. Okay, so the COPD would come under this airway. If there is some parenchymal abnormality which requires ventilatory support, this becomes a breathing indication because you need to put the tube in and connect it to the ventilator. Right? If there is some circulatory abnormality, yeah. If there is a profound shock, what will happen is that the oxygen consumption by muscles will be too much. Now the point, when vital organs are not getting any oxygen and the muscles are consuming a lot of oxygen, it's prudent to offload this oxygen consumption by assisting the respiration by ventilator. So in patients with profound shock, the respiratory muscles, you offload the respiratory muscles by putting the patient on ventilation. The ventilator takes care of most of the respiratory efforts. Now the existing cardiac output can be diverted to various other important vital organs. So circulatory abnormalities. Disability. We have seen that the patient has very poor GCS, Glasgow Coma Score. The patient is not able to. This is an indication that patient will not be able to maintain airway. Right? So you need to intubate the patient. E stands for expected course. Now this is a very important concept. Expected course. If you think that the patient is expected to deteriorate further, or if the airway is expected to deteriorate and collapse, why not secure it upfront in a planned way, in a semi-emergent way, rather than rushing at the last moment and inviting a lot of complications? So the expected course, for example, if the patient is borderline, this is true for borderline patients who do not form an indication for intubation right away, but you feel as a physician that they may require it in some time. So if a borderline patient is sent for a CT scan, this is a risky area. This is a very, very risky area. There is no provider there who would be able to take care of the patient's worsening status. So if there is a borderline patient, you want to get an imaging done, CT or whatever other imaging, it's prudent to overtreat and intubate the patient upfront. If the patient is sent to other hospital, sent out to other hospital, anything can happen en route, which would be very risky. And so in the interest of the patient, it's always good to intubate a patient which is borderline and may require subsequent intubation anyway, right? If the patient has caustic injury with some signs of airway damage, he may be very well conscious and conscious and stable looking in front of you. But the caustic injury, for example, anaphylaxis, for example, this may proceed very, very fast to complete airway shutdown, complete airway collapse. And at that time, your attempts for intubation will fail. The only option would be left would be surgical airway, which has higher complication rates. Right? So in these conditions like caustic injury, anaphylaxis, one other example is expanding neck hematoma. This will externally compress your airway significantly and distort the anatomy, so making things more difficult and prone to higher complications and mortality. Why not intubate such kind of patients with a poor expected course early? F stands for feral, which refers to agitated delirium patients. The patients who are so agitated that they require restraining, and the providers are not even able to do a proper examination and history taking on such patients. These patients are very, very risky and usually have an underlying life threat or fatal condition. So this is very, very risky condition. So if the patient is having an agitated delirium, he is, he falls in the category of feral for intubation, indication for intubation. So A, B, C, D, E, F to remember easily. Indications for intubation, yeah? So looking at this question, profound septic shock, yes, it's an indication. Followed by caustic ingestion causing drooling and saliva, drooling, and even if the patient is conscious, yes, this is an indication. The first option was unconscious patient with trauma with GCS less than equal to 8. Yes, this is an indication. Now, foreign body aspiration causing partial upper airway obstruction. Foreign body aspiration causing airway obstruction, yes, this becomes an indication. Partial is not an indication. If there is partial airway obstruction, the method is encouraging the patient to cough out the foreign body by him or herself. Right? So the correct answer would be foreign body aspiration causing partial airway obstruction. Okay, so we've talked about airways and a lot of things. So what is a difficult airway or difficult intubation? So we remember it by the mnemonic lemon. L stands for look externally. To see by gestalt. So physicians gestalt to see whether the patient has a difficult or likely difficult airway. If he has maxillofacial injury, significant maxillofacial injury, if the patient has significant obesity, right? If the patient has some neck abnormalities, by the look of it, you can say that the patient has an anatomically difficult airway then. Next is E, which stands for, so the E stands for look, L stands for look externally, E stands for evaluate. Yeah. So E stands for evaluate 3, 3, 2. Again, how do you do this? This is an upper airway evaluation. You take patient's fingers. These numbers refers to the number of fingers required. So the patient's fingers is used. Right? So the 3 fingers, if the patient is able to put 3 fingers between the incisors vertically, that is, the inter-incisor distance is 3 finger breadths, patients. If the distance between the chin and the hyoid bone, which forms the floor of the mouth, is 3 fingers or more, and if the distance between the hyoid and the thyroid, that is the thyromental distance vertically, is 2 fingers or more, this suggests an adequate airway. So I'll give you a rough drawing. This is an open mouth. Okay. Suppose this is the patient. If the patient is able to stick 3 fingers in the mouth vertically, this is 3, from the chin to the hyoid, if there is 3 fingers here, and from the hyaloid to the thyroid there are 2 fingers, right? If the patient can put it that way, the patient has an adequate E. M stands for Mallampatti scoring. Okay, these are fancy terms. You need to make the patient sit up and open the mouth wide. You need to see what you see through the mouth. This is the orifice, tongue, the teeth. Usually you'd see some teeth here as well, right? So you can remember this has 4 grades: grade 1, 2, 3, 4. In grade 1 and 2, you can remember it as push, P-U-S-H. P stands for pillars, that is tonsillar pillars. U stands for uvula. S stands for soft palate. And if we get rid of this, H stands for hard palate. Okay? So if you can see all of these, this is grade 1. If you can see only USH, that is uvula, I'll demonstrate how that looks like. We can see this whole picture. This is 1. If you can see only this much properly, this is 2. You can see only uvula. If you see only soft palate and hard palate, and uvula is not visible, this kind of a picture, then it is S. And if you see only hard palate, not even the soft palate is visible. This is 2, this is 3, and only this is present, this is 4. So grade 3 and 4 are considered difficult airways. Grade 1 and 2 are okay. Right? So this is Mallampatti grading. This is M. O stands for any obstruction or obesity. Obstruction means like if the patient is COPD, or you know that there is an upper airway obstruction by history or patient's presentation. N stands for neck mobility. You need to check the patient's vertical neck mobility, and if it is restricted in both extension or flexion, this would be a difficult patient to position, and hence there would be a difficult intubation attempt. Okay, hence the E stands for evaluate 332 rule. Okay, if the following is not true. Okay, coming to the next question. Which of the following is not true? Gum elastic bougie is an adjunct to tracheal intubation. Yes, we've discussed that. Airway protection is completed only after ABCD assessment is done. No, that's not correct. D, as I said, is approached only after ABC are stable. You may require B and C assessment to assist you for airway control at many times, but the D usually is assessment done later, only after ABCs are controlled. There may be some indications for intubation once you assess, only once you assess the disability part, but that comes later on, right? So this is not a right statement. Capnography is very useful for assessing the correct tube placement. This is right. Capnography refers to a method of recording carbon dioxide end tidal. That means you put the tube inside, you put a detector. So this is the tube inside. You put a detector here, which is known as the side port, or there are two sampling techniques, side port and the main port technique. By whatever technique, you sample some CO2 here, and this gives you a recording of your end tidal CO2. So this is known as waveform capnography. This is the gold standard for assessing the correct tube placement. So this statement is right. Surgical cricothyroidotomy is preferred over tracheostomy in emergency situation. Yes, I have discussed that. Tracheostomy has higher complication rates and requires a surgical expertise. Cricothyrotomy on the other hand is easier and can be performed in the emergency department itself. However, having said that, there are some conditions where cricothyrotomy would not be done or would not be feasible or would be contraindicated, and directly one would switch to tracheostomy. But as a general guide, surgical cricothyrotomy is preferred over tracheostomy in emergent situations in the emergency department. Okay. Hope you're getting the concept of airway, breathing, circulation so far. Okay, coming to the next question, which of the following is not a risk factor for post-intubation cardiac arrest in the emergency department? So we have discussed post-intubation cardiac arrest is the most devastating risk factor outcome, right? Of the various other complications, if the patient develops cardiac arrest, this is very grave. So we come to the concept of what is called, we have discussed about an anatomically difficult airway by Lemon assessment. Now once I was discussing the Lemon aspects, you would wonder who has the time to do all these assessments, like look externally is okay, this uses gestalt, evaluation of the 332 rule, looking for the Mallampatti grading, looking for the neck mobility. Who has all this time, especially if the patient is already unconscious or is having a crash airway? You don't have much time, right? And practically also it would not be very possible in very, very unstable patients to do the Lemon assessment or do the anatomically difficult airway. As a rule of thumb, what we do is you anticipate difficult airway in all the attempts of emergency intubation. Okay, so that's how you do. So hence planning for failure is very, very important, because any airway can turn out to be a difficult airway, even if, mind you, even if the Lemon assessment has been done and this suggests a not so difficult airway on evaluation, still this patient can have an anatomically difficult airway once you are going ahead with the laryngoscope. Okay, so planning is very, very important. Another concept which is more relatable to the emergency department is physiologically difficult airway. So these are the conditions on the patient's profile which, if present, usually portend a poor, risk profiling, if the patient, which we refer to as hop killers. H stands for hypotension, O stands for oxygen problems, that is hypoxia, and P stands for pH, which is acidosis. So if any of these is present of the hop killers, they are called killers for a reason, hop killers. So the patient has any of these, this is a physiologically difficult airway. Routine RSI steps need to be modified according to the presence of either of these. Right? You have to be very, very cautious once you're dealing with any of these conditions. Okay, so these are hop killers. So taking this concept, which of the following is not a risk factor? Hypotension, hypoxia, acidosis are. Acute heart failure is not a risk factor. Directly, it can cause, if there is cardiogenic shock, it can cause hypotension or acidosis. And if there is significant pulmonary edema, that can cause hypoxia. But independently, these are the three risk factors for post-intubation cardiac arrest. Okay, so this is in whole and in total about discussion about emergency airway and some aspects of breathing as well. So we've discussed about when to intubate a patient, when to consider airway protection in the form of indications, that is A, B, C, D, E, F. We've discussed what is the standard technique for airway protection, that is RSI, rapid sequence intubation, and the various steps involved. You've seen what is a difficult airway both anatomically as well as physiologically, and some other concepts regarding decision making and initial evaluation of a patient in emergency department. Now coming to the next question, which is the following is not a cause for hypotension with raised jugular venous column. Okay, so hypotension and raised JVP is caused by, before that, let me tell you some causes for shock. Well, hypotension is not equivalent to shock. First of all, there is something called cryptic shock or occult shock, which usually precedes, right? This can lead to hypertension subsequently, but usually this is not usually what this as a concept. Hypertension is not equivalent to shock. Shock may be present even without hypotension. That's an important thing to understand and remember. Having said that, shock can be hypovolemic, cardiogenic, distributive, obstructive, septic. Some of you may think about septic shock as one of the examples of a distributive shock, but no, this is a different thing. Septic shock has always to be classified separately. Hypovolemic shock, loss of volume, causes decreased cardiac output as per Frank-Starling principle. Decreased cardiac output causes hypoperfusion, right? Hypovolemic shock. It's treated by volume. Simple. Cardiogenic shock is a pump failure. It could be primarily by the pathology in the pump, or secondarily by a systemic or an external thing which causes a effect on the pump. It causes forward failure and congestion, that is backward failure. What does it mean? In the forward failure, the pump is not able to generate enough power and therefore causes hypoperfusion and hypotension, and congestion because it's not able to maintain the volume, take in all the volume which is coming to it, so it causes congestion and upfront accumulation of fluid and blood, which causes congestion, especially in the lungs. So there could be right-sided heart failure and left-sided heart failure. In the left-sided heart failure, the congestion is in lungs. In right-sided heart failure, it is in systemic circulation. That is peripheral edema. I would rather say edema in general. Okay? Distributive shock, loss of tone. Loss of vascular tone because of various reasons, one of the most common and most important of which is neurogenic shock and anaphylaxis. Right? What happens in these is the loss of vascular tone, the sympathetic tone goes away, and there is a pooling of blood into peripheral vessels. What are the capacitance vessels? The venules and veins, thereby decreasing the venous return. In obstructive shock, there is, by the name itself, there is an obstruction. Typical examples include cardiac tamponade, massive pulmonary embolism, and tension pneumothorax. Septic shock has components of hypovolemia, cardiogenic, as well as distributive. Right? So this is a different kind of a shock with various components and bits and pieces. Depending on the stage and depending on the physiology of a particular patient, any of these components can predominate. Hence, it is considered to be a separate etiology. So shock is hypovolemic, cardiogenic, distributive, obstructive, and septic. Okay, hypovolemia, distributive, and even septic shock. These patients will have low JVP because volume is either not there, is pooled peripherally, or a combination of both, right? So these patients will have hypotension with low JVP. Cardiogenic shock, there is congestion. Obstructive shock, there is inability to enter inside the heart. So these will have high JVP. So cardiogenic and distributive shocks will have high JVP or elevated jugular venous column. Even septic shock may have it, but usually later stages of resuscitation. Typically, these two have raised JVP. Okay. So where were we? Yeah. So hypertension with raised jugular venous column is seen in this. Constrictive pericarditis has raised JVP, but it's not an immediate cause for hypertension unless there is a superimposed thing, like there could be a cardiogenic component depending on the etiology of constrictive pericarditis. If it also causes cardiogenic stunning, there could be a component of hypovolemia superimposed, or obviously a septic component. If they are superimposed on constrictive pericarditis, then it can cause shock, not directly as such. Which of the following is not a cause for bradycardia and hypotension? Okay, so again there's a very important component, bradycardia and hypotension. To remember the concept of bradycardia and hypotension, usually we remember it by the mnemonic of paste. Before that, I'll tell you some common causes. Like one is unstable bradycardia, right? Complete heart block, second degree heart block, and any n number of things which are unstable by definition will have either hypertension as one of the components, right? This one is unstable bradycardia. Next would be hyperkalemia. This slows down everything. Most of the time it causes a brady kind of a picture, and whatever is the rhythm or morphology will come down and cause bradycardia with possible shock. Okay. Then we have myocardial infarction which can complicate bradycardia and cardiogenic shock. Right? One important component is hemorrhagic shock. Now you will say typically hemorrhagic shock is a kind of hypovolemic shock. Hypovolemic shock is usually associated with hypertension, not hypotension. But yes, if there is associated hemoperitoneum, this can cause vagal stimulation and cause bradycardia. So hemorrhagic shock in up to 10 to 15% patients will have no tachycardia, and some of them will have bradycardia. In a trauma patient, typical of brady plus hypertension is of neurogenic shock. Okay. Another thing is hypothermia. This is an important thing. Causes myocardial depression, slowing of the heart, and hypotension. So we have unstable bradycardia, hyperkalemia, MI, some causes of hemorrhagic shock, neurogenic shock, hypothermia. These are general causes of bradycardia with hypertension. Now we come to toxicologic causes. This is an important entity, toxicological causes, which can be grouped as PASTE. P stands for poppy, which is opioid overdose, propranolol, which means beta blockers. A stands for acetylcholinesterase inhibitors such as organophosphates and carbamate. Toxicities. C stands for calcium channel blockers, clonidine, carbon monoxide, cyanide. E stands for ethanol and other sedatives or sedative hypnotics. D stands for digoxin and other cardiac glycosides like oleander, which has digoxin-like effects. Okay, so we talk about paste. So paste plus these are causes of Brady shock, right? We come to this again. Not a cause for bradycardia. Opioid overdose is yes. Calcium channel toxicity, organophosphate, tricyclic antidepressant is not a cause. What tricyclic antidepressant does is has an anticholinergic effect and thereby tachycardia. This is quite important. Tachycardia is an important feature for tricyclic antidepressant toxicity and not bradycardia. Okay. Coming to the next thing. Now we have seen shock, Brady shock and other things. Which of the following is true about normal saline as an initial fluid of choice? Okay. So let's talk about the fluids of choice. Fluids in shock then, first of all. So the fluids may be crystalloids, colloids. The difference between the two is presence of osmotic molecules are present in this and absent in this. Typical example are Ringer's lactate, normal saline, plasma light. Okay, for the fluids we have crystalloids, colloids. Osmotic molecules are present in colloids and absent in crystalloids. The typical example of crystalloids include normal saline, Ringer's lactate, and plasma light. And for colloids include gelatin, HSS, which is starch, and blood products, as well as albumin. Okay, so which do we use? So there is no definitive, very definitive evidence as to prefer one over the other, but general consensus states, and which is reflected in various guidelines as well, that crystalloids are the fluids of choice for patients with hypotension. And if you're considering fluids as a treatment, crystalloids should be used. Problem with the colloids is coagulopathy, renal failure. These are two important things, and with blood products and albumin, this also includes transmission of infections, plus obviously cost. Right? With gelatin, there is also a risk for allergy. So these are the things which impair our use of colloids. And the choice is crystalloids. Even among crystalloids, these two are the most common and the most debated ones. There is no consensus as to use NS or RL, which of them is superior, which is not. There is no consensus as such, but there is an evidence by recent trials that RL or any balance salt solution, which is called BSS, balanced salt solution, like RL, is preferred over normal saline. To remember this, just remember, there's no need to even write it down. There is nothing normal with normal saline. So normal saline is bad. It is devil. RL, Ringer's lactate, is good. What are the problems with normal saline? It has 154 milliequivalents per liter of sodium and chloride. This is a very high chloride content. Very high chloride content. Right? This causes hyperchloremic metabolic acidosis. A simple key concept to remember which fluid will cause what as far as acid-base equations are concerned is to subtract sodium minus chloride and C. If the difference between sodium and chloride is equal to 24 to 28 usually, then it is neutral. If the difference is less than 24, this is acidosis. This is an acidotic fluid if infused in large volumes, and if it is more than 28, this is an alkalotic fluid. That is, it will cause and change the existing pH of the body, pH of the blood, towards either acidotic side or an alkalotic side, depending on this difference. So this is the rule of thumb. For sodium chloride, that is normal saline, this difference is 0. Therefore, it is highly acidotic. This is a problem. So metabolic acidosis, which is hyperchloremic, that is non-anion gap metabolic acidosis. This has its effects on renal function as well. It causes poor renal function and predisposes to acute kidney injury, especially in sepsis. So this is a bad fluid, bad fluid. So normal saline is not very good. RL, that is Ringer's lactate, is preferred. Ringer's lactate has a sodium. RL has a sodium of 130, somewhere around 130, and chloride of 109, right? So 130, 128 and 109. So the difference is somewhere around 21, 22. Yeah, which is cool, which is good. This does not cause a lot of acidosis, no acidosis in this, even if you infuse it at higher rates, higher volumes, right? This is not a problem. Okay, so as far as the fluids are concerned, crystalloids are preferred over colloids. Among the crystalloids, Ringer's lactate is preferred over normal saline. Let's come back to the question now. Yes, talking about normal saline, it may cause non-anion gap metabolic acidosis, NAGMA. Yes, hyperchloremic metabolic acidosis. This is true. Is it shown to be better than balanced salt solutions? No, this is not correct. Balanced salt solutions are better in septic shock. It may result in metabolic alkalosis? No, it causes acidosis. And since we have seen that this is an acidotic fluid, NS is used as a treatment of choice, the fluid of choice for metabolic acidosis. So that is a condition. Metabolic alkalosis is a condition where you would use NS instead of RL because you want acidosis. Okay. It must be given as initial bolus of 30 ml per kg in all patients. In all the patients, no, this is not right. So the initial volume of resuscitation is 20 to 30 ml per kg, especially in hypovolemic or septic shock patients. That's true. But you need to see various other comorbidities. The patient has a kidney problem. The patient has a liver issue. The patient is already hypervolemic. Or I'd rather say edematous, etc., etc. If any of these is present, then this amount needs to be brought down, even if the patient is an elderly. This amount needs to be brought down and needs to be titrated. It's very important that it has to be titrated depending on the patient's physiology. And for all the patients, this is not correct. Not correct. Which of the following is true? this is true. Okay, that normal saline may cause non-anion gap metabolic acidosis. Okay. Okay, we come to the next question. While adequate fluid resuscitation and hemodynamic monitoring are of paramount importance when treating the septic patients, which of the following physiological markers has been de-emphasized? Okay, so which brings us to another concept which is called early goal directed therapy. Okay, so this is done in patients with severe sepsis, septic shock. Mind you, I'm telling you about this is an old concept, based on an old concept. Okay, recently things have changed. I'll tell you about that as well. If we talk about a recent old concept, for that matter, there is something called early goal directed therapy or EGDT in severe septic and septic shock patients. In this, we target various steps and there is a time dependent treatment. Early, time dependent treatment and goal directed. Okay, so the various goals are an MAP of more than 65, that is mean arterial pressure. How do you calculate MAP, by the way? It's 2/3 of diastolic plus 1/3 of systolic blood pressure. That is MAP. Okay, so that is one thing which you need to monitor. So the MAP of more than or equal to 65 mmHg, CVP, central venous pressure, of more than or equal to 8 to 12. Okay, next is SCVO2. You don't have to remember all these values as such, but the goal directed parameters include MAP, CVP, urine output more than 0.5 ml per kg per hour, and hematocrit needs to be kept more than 30%. So this was an early goal directed therapy, concept of early goal directed therapy, which was brought about in 2001 by Rivers et al. A landmark monumental trial, the EGDT trial, which said that using these targets has very important mortality benefits in septic shock patients. Okay, but this was way back, around 17 years back, right? So there is a lot of new evidence and newer studies which have come up, which have challenged the early goal directed therapy. Now it has been clearly stated that central venous monitoring, or maybe targeting central venous monitoring, is not useful. So CVP targets and SCVO2 targets are out. They are not important. Okay, even hematocrit of more than 30% has not been shown to be of any benefit further. Important targets still include MAP of 65, urine output of more than, and something which has been added is lactate. This is an important marker for hypoperfusion and shock. So if the lactate is more than or equal to 4, this is bad to begin with. But if this improves, like 4 to 2 to 1, this is good, right? So if the lactate initially is 4 or more, this is bad. But the lactate clearance, this is called lactate clearance with treatment, can be used to monitor therapy, and that is good. So lactate is one which has replaced central venous monitoring. So this has replaced. Okay, so lactate is good. And central venous monitoring has been thrown out. Not very, very important. Okay, so this is early goal-directed therapy as was initially discussed by Rivers et al. But now various parameters have been challenged and the new evidence does not support the use of all the parameters in the early goal-directed therapy. More so, that some of the studies and important recent studies also say that the early goal-directed therapy, that is the bundled approach, is also not important. It does not improve mortality. Well, that is a controversial area and I will not delve into that too much. But just remember that CVP and SCVO2 are out. They are not important in management of patients with sepsis. Okay. Okay, so the answer de-emphasized is CVP. This is not very important. Okay. Coming to the next question. So this is a 30-year-old female presenting with fever and one episode of seizure 8 hours back. Currently she is neurologically intact and hemodynamically stable. That's good. So far so good. Now, you decided to get an imaging done. Contrast enhanced CT scan of the head was obtained in the emergency department. Immediately thereafter, okay, contrast enhanced CT. And immediately thereafter the patient developed sweating, shortness of breath. She is now conscious but has tachycardia, hypotension, tachypnea. Bilateral V's can be appreciated on auscultation and there are multiple raised purpuric erythematous rashes on all 4 limbs. Okay, so what exactly went wrong? So the contrast has been known to cause allergy. Right? So the patient is contrast allergic. This can land up into anaphylaxis. How do you recognize anaphylaxis? If there is a known allergen and the patient presents with hypotension, this is anaphylaxis. Okay? If the patient has suspected allergen and presents with okay. If the patient has a suspected allergen and it presents with any 2 or more system involvement, which include skin or mucosa, that is mucocutaneous, gastrointestinal, respiratory and cardiovascular. Easy to remember, right? Important systems and obviously the urticaria and things are quite commonly known. Okay, so if all the 4 systems which are potentially involved in anaphylaxis, any 2 or more are involved, this is anaphylaxis. Okay, so you need not have hypotension all the time. Okay, so shock is not necessary mind you, to diagnose anaphylaxis. On the other hand, as you can see, shock alone or hypotension alone can be a feature of anaphylaxis. So this is basically sometimes a difficult diagnosis to make and it should be suspected upfront, especially all patients with septic shock. All patients in which a diagnosis of septic shock is made, all patients with a diagnosis of septic shock should at least be considered for a diagnosis of anaphylaxis. All patients with erythroderma, all sick patients with erythroderma, generalized erythroderma, you should suspect anaphylaxis. Okay, so these are some triggers, some presentations which should trigger your thought process of considering anaphylaxis. And then obviously you can look for involvement of other systems and things, and then you'll be able to diagnose anaphylaxis. So in this patient, let's see what we have. We have cardiovascular involvement, we have respiratory involvement, we have skin involvement as well. So 3 systems are involved, and hence this is anaphylaxis. Okay, right. So the treatment of anaphylaxis. Now, the treatment of anaphylaxis, and the only known treatment to improve, which is shown to improve the outcomes, is only one, that is epinephrine, also called adrenaline. Right? How do you give it? It's very important to give it right. I would say rightly administered epinephrine is a treatment of choice. So usually it is available in the form of EpiPen, which is preloaded epinephrine, but that's many times not available to us in India here, to the patients here. So we need to remember how to administer epinephrine. So this is given intramuscular. Okay, not subcutaneous. It's very important to give it intramuscular. Dose is 0.3 to 0.5 ml. Okay. Concentration is 1:1000. So this concentration 1:1000, which is commercially available in this form only. So 1:1000. 0.3 to 0.5 ml is given intramuscular in anterolateral thigh. Okay. Every 5 to 15 minutes. This is the complete prescription as to how you give epinephrine in patients with anaphylaxis. This is how you should give it. Every part of prescription is important. It's intramuscular, not subcutaneous, not IV. Okay. This is the dosing. This is the concentration. This is the site, not gluteal. Okay, why so? Why to be so specific? Anterolateral thigh. What we need is the correct drug to be administered at correct rate. Correct rate of absorption as well. What's the problem with IV? It's the fastest absorption. No, but IV drug administration of epinephrine has higher arrhythmia rates. Higher arrhythmias and increased side effects. Because it's not a benign drug. So we need something which is a balance between adverse effects and rates of absorption. Subcutaneous, no. Because there is no proper absorption ensured. So there is less absorption. So systemic availability of drugs is less, of the drug is less. Also, gluteal, as compared to gluteal and at the deltoid region, anterolateral thigh has been shown to have best availability, bioavailability, and most reliable absorption. Curves. Okay, so it has to be given in anterolateral thigh at this dose and intramuscularly. It's very important. Okay, other treatment of anaphylaxis like H1 blockers, H2 blockers, steroids, these are all adjuncts. These are not standard treatments like epinephrine. Okay, so these are adjuncts. They have never been shown to have mortality benefit. Only thing which saves life is epinephrine. Only thing which saves lives is epinephrine. Okay. So the patient developed anaphylaxis. Okay. So what would be the next step? Intramuscular epinephrine right away. Okay. IV bolus of epinephrine? No, because of increased adverse effect. Intubate the patient stat? Well, not yet. The patient does not have any signs of upper airway collapse, but you have to be very, very vigilant as to development of angioedema, as we saw in the previous questions. Okay. So intubating the patient would be considered as one of the steps, maybe later, but not the next step. Okay. So this is not right. This is not right. High dose of steroids to take care of the medium vessel vasculitis. Okay, this is not vasculitis at all because of the temporal correlation and the high possibility of anaphylaxis. Steroids may be used, but again, as I said, these are not standard treatments which save life upfront. Anyway, steroids take around 4 to 8 hours to act. Okay, so anaphylaxis, in anaphylaxis, steroids may be considered maybe later on, but not at the expense of administering intramuscular epinephrine. What about broad spectrum antibiotics as per Survive Sepsis campaign? No. So Surviving Sepsis campaign basically campaign guidelines. SSC guidelines are present. Guidelines are internationally accepted guidelines for management of sepsis. And broad spectrum antibiotics are an important part of that. But this does not look like sepsis upfront because the patient does not have any signs suggestive of that, an ongoing infection or sepsis. Okay, so this is probably not accurate in this case, and indeterminate use of antibiotics should be avoided. So intramuscular epinephrine is the answer of choice.